Good morning. I'm Howard Snyder, surgeon at Children's Hospital, and I'm the lead-off introducer because I am a trustee of the College of Physicians and want to explain a little bit about this venue. The College of Physicians is the oldest medical establishment in America, being founded in 1787 by Benjamin Rush and other colleagues here in Philadelphia to improve the dialogue between the public and the medical profession to improve the health of the population of Philadelphia. And we've continued to exercise that mandate. So the college is a very suitable venue for this quality improvement meeting. And I hope you'll wander around the college a little bit. The Mutter Museum is now ranked as one of the tourist attractions in Philadelphia, and return often. I'm going to introduce Marshall by saying that many of us in organized medicine have realized that we're about 20 years late in getting started to help reform U.S. healthcare, because physicians have to be involved. Administratively, it's questionable whether you can purchase quality and efficiency on administrative guidelines alone. It takes physician guidance, and you'll hear this morning about that. With that, I'll introduce Marshall Schwartz, the Chief of Pediatric Surgery at St. Christopher's, and also a regent, as I am, of the American College of Surgeons.
Thank you, Howard. First of all, I want to welcome everybody to this forum. And what we really are trying to accomplish this morning in the next hour and a half is to, one, give some brief introductions, have the panelists talk about their experiences very briefly. And when we say briefly, we're talking about 5 to 8 minutes, because what we really want is audience participation. And so half of the time of the hour and a half is for you, the audience, to ask questions and get involved, because you're here because you're interested in this topic. And therefore, we want you to be able to ask questions. We're not going to claim that we have all the answers, but we'll certainly give it a try. So what I'm going to do in just a few slides is try to introduce the role of the American College of Surgeons in the topic of healthcare, and particularly as it relates to inspiring quality in surgical healthcare. This is something that the American College of Surgeons has been involved in for quite some time, and I will give you some details about that in a moment. But it's been inherent within surgeons to address quality since the inception of the American College of Surgeons. But quality right now seems to be the topic in this country, and many of the organized medicine organizations have focused on quality. And a few of them are listed here, and they represent government entities such as the National Strategy for Quality Improvement in Healthcare, which is an HHS committee, the CMS Committee on Triple Aim, et cetera, et cetera. And the American College of Surgeons felt that this was an optimum time for us as surgeons, but really physicians in general, to get engaged in this debate and to talk about quality of care as well as cost reduction. What's important to know is that the American College of Surgeons, which was started in 1913, began to focus almost immediately on quality of care. And that was through this effort going way back in 1917 to try to standardize health care in hospitals, and particularly care of surgical patients. because they recognized at the time that there wasn't any standards, and there was a great deal of variability in healthcare of patients, and particularly surgical patients. And if you look at this timeline, you see that surgeons in the American College of Surgeons have been involved in healthcare quality throughout the last 100 years through the institution of the Commission on Cancer to improve cancer care and to make it a multi-specialty effort and not a silos. The Committee on Trauma and the ATLS system of training people to take care of trauma patients and to have a system of transport. One would have thought this would have evolved a long time ago, a lot sooner than in the 50s, and it started in the 50s, but it took a good 15 years to really get people on board with this concept. And as you go through up until now, you see the National Quality Surgical Improvement Program, NSQIP, which is what we're going to be talking about today in some detail. And what we want to do, and all of you should have in proximity, maybe not this little cube, and what this represents are the pillars of quality care for the American College of Surgeons. And this is the first point on this cube is setting standards. If you don't have standards, you don't know where you're going, and this is a critical piece of this. This has to come from data, and so the basis of the NSQIP program, in addition to trying to standardize care, is to collect data so you know what you're doing and where you have had improvement. The next is you have to have an appropriate structure and infrastructure, where it's the staffing levels, having the appropriate physicians and specialists available, the right equipment, and then a checklist to make sure that everything is in order. The next is a rigorous data collection from medical charts, not from physicians' memories or data that is not accessible, and that there has to be a very good way of categorizing that data, and then verification through external peer review and publications. And these are the pillars that really are the monitor of the American College of Surgeons. So just to give you a little bit of information on the NSQIP program and the impact that this has had, a paper that was published in 2009 in the Annals of Surgery represented data from 118 hospitals, and that data was collected from 2005 to 2007. And what was gathered from there is rather remarkable, frankly, and it showed that on average in each of the 118 hospitals that there was a reduction in complications, and the reductions ranged, depending on the size of the hospital, between 250 and 500 complications per year. 12 to 36 lives were saved as a result of these efforts in this program, and there was a significant reduction in the cost related to not having to care for those complications. 82% of the hospitals showed a decrease in complications after initiation of this program. 66% of the hospitals showed a reduction in deaths, and again, the number of complications overall per hospital reduced. So this is really somewhat of a bottom line, which we're going to be talking about in more detail. But a very conservative estimate of the cost of a complication is $11,600, and we all know that it could be many more times that, but just for purposes of discussion. So if you extrapolate that as the cost of a complication and multiply that by the number of complications reduced per hospital, you get this kind of a savings per hospital, which I think most hospital CEOs would be happy to save $2.9 to $5.8 million a year, and this is a mechanism on how to do that. And if you extend that to approximately 4,500 hospitals that currently exist in the United States, that gets to be a big number of $13 to $26 billion. And if you extend that over 10 years, which Washington likes to talk in 10-year time frames, this is a lot of money. This is $130 to $260 billion that you could save in a 10-year time frame if you had instituted a program that addressed the pillars that I talked about in terms of standards, et cetera, and you were able to reduce complications. But this isn't theoretic, because the data that I showed you is real, and it has continued. And now there are 475 NSQIP hospitals and 50 children's hospitals or children's centers that are involved in a pediatric version of NSQIP. And this data has continued to show these reductions in complications and the cost savings. Oftentimes, there's a disconnect, and people are talking about quality of care or cost of care. People talk about cost or they talk about quality, but they usually don't talk about it in the same sentence or in the same discussion. But there is a clear connection between quality and cost, a reduction, and the NSQIP program demonstrated that by showing that when those things do overlap, you can save hundreds of billions of dollars in a 10-year time frame. So with that, I'm going to show a 2-minute video. This is referred to as an anthem video. It goes by very quick. It's music and stuff, but it was put together, and I think it kind of summarizes what I just mentioned over the last few minutes.
I want to acknowledge one other individual in the room. We have Mark Malagoni here, who is a general surgeon on the American Board of Surgery, and he is also a governor as a regent of the American College of Surgeons. That would be appropriate. I'm here to introduce our keynote speaker, who is Congressman James Gerlach, who happens to be my congressman because I live in his district. And he's been pivotally important in U.S. healthcare because he sits on a committee of jurisdiction. He's on the health subcommittee of House Ways and Means, and that's how all the spending bills get started. So he's going to have an increasing role to play, and I think we're very fortunate to have a excellently motivated, highly intelligent congressman, and I can say that with authority since I've spent a lot of time in his office lobbying for the American Urologic Association or the American College of Surgeons, my two professional organizations. And I can promise you that his staff, as well as the congressman, are really advocates of U.S. healthcare. So without further ado, let me say a word about the cube. We have a fancier version of the cube here to present you, Congressman Gerlach, which is right here. And we hope you'll take this to Washington and put it on your desk and realize the American College of Surgeons is leading the way. Thank you.
Thank you very much. Well, good morning, everybody. Thank you so much for the opportunity to be with you. Thank you for that kind introduction, Doctor. Great to see you again, and great to be with you here this morning in Philadelphia. First of all, I was struck by your initial comments, Doctor, about the origins of this college, all the way back to Benjamin Rush, known as the physician of the Revolution. And my personal connection with Benjamin Rush is that he did another thing. He started another college also, Dickinson College, and I am an alumnus of that college. It was not started by John Dickinson, as many people think. It was actually started by Benjamin Rush, who wanted to start a higher educational institution out on the frontier of our colonies. And back at that time, Carlisle in central Pennsylvania was on the frontier. So he formed the college and named it for his friend John Dickinson, who in turn continued to support the college through its start and through its initial growing. But Benjamin Rush clearly was a leader back in his time, and his leadership continues to be felt today in many, many different ways, including this college and Dickinson. The assignment that I have this morning is to give you a little bit of a legislative update on where things stand with many important issues facing you as surgeons, and maybe see where that intersects with the theme of your program here today on quality improvement, and how perhaps we can figure out how to bring government and regulations and reimbursements in line with what you want to do, and that's provide increasingly better care and better outcomes for those that you care for. And so how that all plays out still is going to be somewhat of a question and sort of speculative in the coming year or so, but perhaps we can all work together to try to get those lines to intersect. As you know, at the end of this year, the SGR, Sustainable Growth Rate, issue is going to be on the front burner as we get to the lame duck period between the election and the end of the year. The question of whether there'll be a 27% reduction in the reimbursement rate for those that care for Medicare seniors becomes a big question for the Congress and for the White House. Again, if nothing's done, a 27% reduction in reimbursement occurs. And so will Congress take up a piece of legislation to prevent that from happening and prevent that kind of loss in reimbursement, which in turn would result, I believe, and many others believe, thousands of physicians giving up practicing in the area of Medicare senior health care and focusing their practice on other areas that can provide more income for their ability to continue with their practice and continue with their working life. I think the prospects for passage of an SGR fix are good, although there's no specific proposal on the table right now, only because there's very little discussion between the House and Senate leadership and the White House about anything that will happen in the lame duck period. We have that issue. We have what's called the fiscal cliff or tax-mageddon, depending on the term you want to use, where at the end of the year, if Congress does nothing, the current law is such that all of the 2001 and 2003 tax rates snap back up to their higher levels, all individual marginal rates, capital gains, dividends, interest income rates snap back up. The estate tax goes back up from 35% to 55%. The child care tax credit goes back down from $1,000 per child to $500 per child. All that happens at the end of the year if Congress does nothing. We also have the issue of what's called sequestration, whether or not at the end of the year if Congress does nothing, the commencement of another $1.2 trillion of spending cuts at the federal level over a 10-year period will begin. About half of that on the defense and intelligence side of the budget, but the other half of that on the non-defense side, including another 2% reduction in Medicare reimbursements for those that provide care. So very, very important questions relative to what's going to be the ability of our physicians and our surgeons to get proper reimbursement for those that they're caring for that are tied to a federal program like Medicare. And eventually I think these issues also come into play relative to those that care for Medicaid patients. But right now the main focus is on Medicare and the health care providers that provide such important service to our seniors. Are they adequately going to be paid for what they do? And how should that payment be structured? What factors should be considered in determining that pay, that reimbursement? Should it just be the volume of care, the frequency of service, a diagnostic code that says you did this, therefore this is what you get out of the program as a reimbursement? Or as you're advocating as a college, so rightfully so, with your values update, your values-based update component to that formula, tying in quality improvement and outcomes in determining how much reimbursement you get for caring for that patient. As we go into next year, our Ways and Means Committee vision has been to try to prevent in the short term, prevent the 27% cut in Medicare reimbursements at the end of the year and extend the reimbursement rate again for a period of time while we come up with a quote-unquote permanent solution to making sure that there's a quality component and that there is a proper definition and formula for providing Medicare reimbursement to physicians, and have a formula in place for an extended period of time, much along the lines of what MedPAC has recommended, and which I think your college has also formally supported, and that is at least a 10-year fix, a 10-year formula that can be counted on, that is stable, that can be something that's predictable in terms of a practitioner's day-to-day practice. And so that is what our Ways and Means Committee is going to be working on as we start the new Congress in January. In talking to our committee staff, they are well aware of your values-based update project or proposal. They are considering it as part of our committee discussions on how we overall reform this SGR formula for a longer, extended period of time. And I look forward to helping to advocate for that as I do my work on the committee. As Dr. Snyder indicated, I'm also on the subcommittee on health, which has a jurisdiction over the Medicare program. And in my opinion, it's going to be absolutely critical that we start coming up with ways not only to save money, but tying those savings into the ability to continue to provide the quality level of care that we want for our Medicare seniors and, of course, all across the spectrum of health care services. I am struck by the fact that we have so much waste and inefficiencies in our system that if we are better able to capture that and correct that, it provides us more flexibility in budgetary decision making in terms of using some of that to spend down the increasing debt that we have as a country, but also making sure with those savings being able to keep the reimbursement levels up at a sufficiently high level that it entices and incentivizes physicians to want to care for our seniors in the Medicare program, make sure the highest quality of physician is able to participate in the program, and that ultimately the seniors get the care that they expect and they've paid to the program for when they were coming through their working years as workers and as taxpayers. The GAO, the Government Accounting Office, last spring issued a report that in 2011, there was $48 billion in the Medicare program of improper payments. The total expenditure of the Medicare program that year was $520 billion. So when you have $48 billion of $520 billion in expenditure that's considered by the Government Accounting Office to be an improper payment, an improper expenditure, and some of that might be just erroneous payments, mistaken payments, but it also is identity theft of seniors' Social Security numbers that are then used for fraudulent transactions, or the interception and theft of the UPIN numbers of physicians, the unique physician identification numbers, that then the thief uses to get on the computer and bill Medicare for fraudulent services. All of that continues to exist today, and as a result, it's a huge amount of money. Almost 1/10 of the total expenditure is in improper payments. We've got to get a handle on those kinds of problems in these programs. And think about if we are able to correct that. $48 billion a year over 10 years is $500 billion. Think of what we can do not only in terms of bringing down the cost of the program overall, but what we can do then also to make sure that there are proper reimbursements for our healthcare providers, a level of reimbursement that keeps our finest physicians and hospitals and home health agencies and rehab facilities available to handle the healthcare needs of those seniors. Think about how those savings can be applied. So as we move forward in this whole process, I would leave you with a couple thoughts. Number one, short term, we need to work together to make sure at the end of the year we don't see that draconian 27% reduction in reimbursements. But then let's figure that this whole effort at reform of the SGR is going to be based upon the fact that we have to understand what kinds of levels of service are going to be needed for seniors when you have 10,000 baby boomers now retiring every single day and coming into the Medicare program over the next 20 years, which is going to complicate and grow this program exponentially in terms of the size of participants or number of participants. So number two, how do we in the long term think about ways to do just what you have on your chart, connect quality improvements and quality care with lower costs? And that's really what you're striving to do, and we're going to have to incorporate your thinking into our budgetary process to meet the goal of taxpayers getting a service for what they've paid for, but taking away the problems of the program that exists today in terms of the waste, the fraud, the abuse, and the inefficiency. So it leads ultimately to a kind of program, a right size of a program that accomplishes those goals of quality care and efficient spending. We have one proposal along those lines that we're excited about that would help us deal with that $48 billion a year of improper payments. It's called a smart card bill. And what it would do is create a smart card, the use of a smart card technology in the Medicare program for both the provider as well as the Medicare senior, where a card would be swiped at the time of the medical transaction so that electronically certain bits of information can be verified about the appropriateness of that service at that time. This kind of card technology is already being used in the Department of Defense to cut down on wasteful spending. It's being used by other healthcare systems around the world to cut down on identity theft and wasteful spending. And we think a smart card technology in the Medicare program would save about $30 billion a year out of that $48 billion in improper payments. We're pleased to see that the American College of Medical Practice Executives have endorsed this legislation, and we just got correspondence from the American Academy of Orthopedic Surgeons endorsing this legislation as well. So hopefully that's an indication that there are folks out there in the healthcare delivery system that recognize much more needs to be done to cut down on this wasteful and inefficient spending within the system. And rather than us in Washington simply getting to the end of a budget year and saying, well, this is all we can spend, so we're going to have to cut here. This year it's going to be imaging. Next year it's going to be rehab, hospital services. The following year it's going to be whatever. Let's figure out a long-term strategy to find the waste and inefficiency in this program and in our system overall, healthcare delivery system overall, and then tie what you have advocated so clearly, quality improvement with lower costs for better outcomes. And we stand ready to work with you from our position in the Ways and Means Committee, and I look forward to that continuing discussion and advocacy, not only as we finish this year with the SGR fix, but also as we get into the larger, more long-term issues of what we reimburse physicians for as they care for our Medicare seniors and what that means relative to our overall budget in the coming 10 years. So thanks very much. I think we can open it up for a couple questions. Is that correct, Doctor? And be glad to get your thoughts and comments. Yes, sir. It's kind of hard to, so raise your hand high. With the light there, it's kind of difficult to see.
Representative Gerlach,
Yeah.
I also am one of your constituents. My name is John Clark, and I was on the Institute of Medicine Patient Safety Data Standards Committee, and I am currently the clinical director of the Pennsylvania Patient Safety Authority. You talked about waste and fraud and identified waste and inefficiency, and you identified fraud as being about 10% of your budget. It's been estimated that a lack of efficacy is about 30% of the problem with healthcare delivery. There seems to be a reluctance to deal with the efficacy of healthcare and to develop nationwide standards. And I wonder if you could talk about this reluctance to deal with the efficacy issue.
Well, I think everybody should recognize that we have to develop clear and better standards for determining who gets what by way of reimbursement, who gets what by way of support from the programs that are there to serve seniors. And just again to do, as I said moments ago, based upon frequency of service and a diagnostic code, and therefore here's the money you get for doing that, is simply outdated and is not going to connect the two goals of lower costs and quality improvement and quality outcomes that we're all searching for. So it seems from my perch that different specialty groups within the overall medical profession are taking steps to try to advance that idea of connecting those dots. And certainly you are doing that here at this college, and there are others that are doing that as well. And it seems to me you need to figure out how to bring some of these specialty organizations within the overall medical community together better on a unified voice and a unified proposal to really go to Congress with and advocate for that kind of change. For example, as I said a moment ago, you have this values-based update component that I think is a very valuable item for us to discuss and try to incorporate. We have a smart card idea that the American Academy of Orthopedic Surgeons, for example, has endorsed. We need to figure out ways to pull some of these wonderful ideas together and bring the pressure to bear in the legislative arena to say, hey, look, you can't go through each budget cycle and just say, here's where you were last year, here's where you want to be next year, and it's going to cost this amount of money, so where are we going to get it to pay for it without getting into the issues that you just mentioned. We have to bring that into this advocacy. We have to bring it into this legislative discussion. And the only way to do that, to get on the radar screens of legislators, is for you to be very active personally and as an organization and be really relentless in your attempt to get on our radar screens as members of Congress and talk about these issues. Dr. Snyder comes down regularly. Marshall's been down a number of times, and we've seen him. So you as a college are well represented and a part of this discussion. But the whole medical profession, it's very difficult. My years in legislative business have taught me that physicians typically day-to-day do what they've wanted, what they have been trained to do, and what they want to do professionally, and that's just care and focus on their patients and care for their patients. This getting involved in the legislative process is very alien to many members of your profession. And yet your voice is such a critically important part of a final policy determination on what we do with these issues. You bring a credibility and a knowledge and a real-world experience that legislators don't have, and yet are the ones that are putting up the votes on what to do. So I would just continue to encourage you as a group and individually to use whatever spare moments you have to get involved in the legislative process and advocate for these kinds of quality changes that we need to have if we're going to save taxpayer dollars, save the programs we ultimately want to save for future generations, and yet do it in a way where quality is what the final outcome is for those patients. So It's a difficult task, but it seems to me there's no other choice because we can't see the Medicare program in 2024 go bankrupt. We can't see drastic reductions in services to those seniors because Congress did nothing. So our only real alternative eventually is to change these programs in a way that takes away the inefficiencies, the wasteful spending, and focuses on lower cost yet quality improvements that you are already doing with the hospitals you're engaged in, and we need to follow that model in Congress. Sir, in the back.
Hi, I'm John Jaffe from Lehigh Valley Hospital. I'm a urologist and also medical director for a large physician hospital organization. There's no question that both inappropriate care and I'm sure fraud and abuse are represent large areas of loss or potential savings for Medicare. The one topic I haven't heard addressed in terms of medical waste is the malpractice situation.
Yeah.
Last I read about, there was about $3 billion spent in Pennsylvania alone in the last 4 years in malpractice payments. And we all know that about 30 to 40% that goes into the pockets of attorneys. I don't think there's anyone in this room who doesn't think that system is highly dysfunctional. And I wonder what, if anything, is going on in Congress. I know nothing really got included in the ACA, but I'd like to hear you speak to what, if anything, is being done to address the malpractice issue.
Yeah, great question. While there's been a lot of debate over the years, both in Pennsylvania, in Harrisburg, in the General Assembly, as well as in Washington, about the need for medical liability reform, nothing has passed yet. But that has not been for the lack of trying, at least on the House of Representatives side. In 2004 and 2006, the House passed medical liability reform. And again, just a few months ago in the House of Representatives, we passed a bill, H.R. 5, that contains medical liability reform. The bill was written by Phil Gingrey, one of our members who's a physician from Georgia. Very important nationwide medical malpractice reform legislation. Also included in that legislation was the repeal of the IPAB provisions of the Affordable Care Act, the Independent Payment Advisory Board provisions, which just virtually every physician organization in this country has objected to as part of that Affordable Care Act, because in essence is going to set up a 15-member board with no real oversight by Congress, who will then in turn look at what the target amount of Medicare spending is, what the actual amount of Medicare spending is, and when the spending is higher than the targeted amount, they will then make recommendations for the reduction of that spending, and in turn be able to make decisions relative to what services get reimbursed, what services don't, frequency of service, etc. And the fear of physicians, rightfully so, is that those kinds of edicts coming out of HHS will improperly interfere with the doctor-patient relationship in terms of what the doctor and the patient believe is the right regimen of care for that patient. We have, again, in H.R. 5, together with the medical liability reform legislation that's part of that, have passed the IPAB repeal as well. And as many pieces of legislation right now, they're sitting in the Senate waiting action. And it's pretty clear that the Senate Majority Leader, Harry Reid, is opposed to medical liability reform. And so ultimately, if we're going to be successful at the federal level on this, it's going to be up to the American people to change who's in control of the House and who's in control of the Senate and who's in the White House. Because it's a very simple formula. You need 218, 60, because you normally need to have 60 votes to close off a filibuster in the Senate, and 1, the president, to sign something into law. So it's 218, 60, and 1. If you get those numbers, you're going to have medical liability reform at a national level. If you get, in Pennsylvania, 102 in the House, 26 in the Senate, and 1, the governor, you'll get it here in Pennsylvania. So it's a simple formula. Elections matter. Who gets elected, who's in the majority, who controls the flow of legislation from committee on to the floor, and then who can sign it into law or veto it, all that matters. So we've been on record in our conference of supporting medical liability reform. Statistic I hear, I haven't had it broken down just to the Commonwealth level, but about $150 billion a year in defensive medicine expenses to our system because of the malpractice climate in the United States, which in turn is then borne by everybody within our insurance system. who have to pay and make up for those $150 billion in defensive costs. So yes, medical liability reform has to be one of the top priorities if you're going to truly do healthcare reform in this country, and we've already been on the record a number of times of passing it in the House. Thank you. All right. All righty. Well, thank you, everybody. Have a great rest of the conference here, and I appreciate your invitation to be with you. Thank you. Thanks, Doctor. Thank you. Very good. Thank you. Appreciate it.
Let me ask the panelists to take their positions on the podium. And as they're getting in position, I cast a little bit into perspective what the congressman said and what Marshall Schwartz said. The last year that health care costs were available in the United States is 2010, and we spent a little under $2.7 trillion on U.S. health care. It's the largest industry in the United States. To give a sense of perspective, this is slightly larger than the GDP of the nation of France. So this is a timely panel to work on quality because we have to. With that, I'll introduce our first speaker, who is John Kokora. John Kokora is the chief of surgery at Abington, which is a NSQIP hospital. John?
Thank you very much. I very much appreciate the invitation from both Dr. Schwartz and Dr. Snyder to be on the panel. I think I'm the only panelist that has had a fairly long working relationship with NSQIP, and I would like to tell you a little bit of my story in that regard. I became the chair of surgery about 10 years ago at my hospital after a much longer career there in surgical education. And one of the things that struck me when I signed my contract was that I was assuming responsibility for providing high quality care and safe care to the members of our community who use our hospital. And in the past, the appreciation of surgical care by chairs and peers was sort of touchy-feely. It was somewhat unmeasurable. There were no real hard standards. You sort of thought that it was a little bit like pornography. I recognize good care when I see it, and maybe I recognize bad care when I see that, but you really didn't have a benchmark or a yardstick to measure it with. Within a couple of years, I learned of the NSQIP program from colleagues around the country, most notably a bunch of my friends from the University of Michigan who were early adapters to this program. And I was really impressed in hearing them speak about the ability to really get hard data about the performance of their department or their divisions or their individual practitioners. When this became clear to me that we should probably join because there was a clear need not only to prove to ourselves as leaders within the hospital that the quality of the product we were delivering was either good or bad, I also realized that nationally we are going to ultimately be measured by this in the ways that the Society for Thoracic Surgeons have measured cardiothoracic outcomes. And I thought this was going to be a good thing for measuring general surgical outcomes in that context. So I took the pain of spending about a year and a half convincing my frugal administrators that this was money well spent, and we got a contract, and since the end of 2007 we've been actively involved in the Essentials program of the NSQIP. I will tell you that this is very valuable. It has prevented, in my own circumstance, being pressured by certain peer review committees that are supposed to drive safety and quality in the hospital from wasting time and effort in areas that didn't really need to have time and effort wasted on them. There was the sense that we need to lower surgical wound infections, but when I actually looked at our data when it came available, we actually had very, very good wound infection rates and consistently among the best in the country. Putting time and effort into that would have been time and effort and likely resources poorly spent. I did find some other issues with our data that led to a identification of critical care staffing issues, and we've instead put the effort into trying to deal with those types of issues. So for setting agendas for change, for setting agendas in terms of where you want to move your department and move the goal, I have found it very valuable. The members of my department have embraced this. They view surgery as a little bit of a team sport, and we like to know how we compete against other hospitals. And all the members of my department look forward to seeing the 6-month report come out and see where we compare with our peers. One of the beauties of NSQIP is that you can compare like hospitals. You have the choice of comparing hospitals by size, hospitals by whether they're teaching or non-teaching hospitals, whether they're for-profit hospitals or not-for-profit hospitals, and that's a really good positive ability to measure. So my experience has been very positive in terms of the acceptance factor by all the members of my department. We give them report cards. They use those report cards for maintenance of certification, which all the surgeons in the room understand is a new expectation of keeping your board certification intact. More recently, we have been collaborating with a regional consortium of 10 hospitals in Pennsylvania to share data, to do site visitations, and I can say that we were happy to host a contingent that was organized through Dr. Clark's organization, the Pennsylvania Patient Safety Authority, but they came to look at my hospital because our bariatric surgical wound infection rates were among the best in the consortium, and they were looking to try to define best practices from that visitation. I think that kind of regional sharing and dialogue is extremely helpful, and I think it's one of the future benefits of this. Finally, we're participating now in a program called the Quality and Training Initiative, QITI, which is a beta test of using NSQIP to benchmark surgical residence performance. We run a robust and fairly large general surgical residency training program. The ACGME, who oversees surgical training, expects all trainees, whatever discipline they're in, to look at their own outcomes and use that to derive a learning plan to improve performance and improve outcomes. So we're happy to say that we are engaging our residents now and being able to log into their outcomes data in the NSQIP, and we have residents now using that to drive personal changes within the resident sphere of care within our department. So I will say it's been a very positive thing. I'm happy to answer questions later in the panel about any of the particular mechanics, but I have found it especially valuable. And for me, I sleep better at night knowing that we swim very effectively with all the big fish hospitals that run big training programs in the country in terms of outcomes. And I feel that that's enabled me to fulfill that expectation of my original job description to provide good care to my community. Thank you.
Thank you, John. It's my pleasure to introduce Dr. Larry Kaiser, who is the Chief Executive Officer at Temple University Health System and the Senior Executive Vice President for Health Sciences and Dean of the Temple University School of Medicine. Prior to this, Dr. Kaiser has had major other medical leadership roles and was the President of the University of Texas Health Sciences System in Houston. Dr. Kaiser is a board-certified general surgeon and cardiothoracic surgeon, and has served on the American Board of Surgery and the American Board of Thoracic Surgery, and in 2004 was elected to the Institute of Medicine of the National Academy of Sciences. So, Dr. Kaiser?
Thank you, Marshall. It's always a little uncomfortable without slides. I recall one session I was on where I showed up and I was the only one without slides on a panel, and today I show up with slides and I'm the only one with slides, so either way it's... I always find it surprising when we talk about quality. I mean, who wouldn't want to have outstanding quality? I think surgeons historically have always been interested in quality. Perhaps we didn't talk about it quite as out in the open as we do now, but if you look at what Ernst Codman was doing at the MGH back in the early part of the 20th century, surgeons were concerned about quality probably before anyone else. We clearly have the Morbidity and Mortality Conference, which of course looks at quality in a retrospective basis, but I think it has allowed surgeons to look at quality and be critical of their own efforts for many, many years. As you know, our medical colleagues are not particularly good about looking at their own complications and their own outcomes, whereas surgeons have been doing it for many, many years. I still am a practicing surgeon, although certainly not to the extent that I used to practice, so I feel somewhat like an interloper here, but I was responsible for bringing NSQIP to the University of Pennsylvania, to the Hospital of the University of Pennsylvania. Rachel Kells is sitting here, who is the surgeon who, at least when I was there, was spearheading that program. And as John points out, there interestingly is some resistance on the part of hospital administration to initiate these programs primarily because of cost. And I think once you get past that, they recognize the inherent value of a program like NSQIP. My surprise is that there are only 400 and some odd hospitals in the country right now that actually have NSQIP in place, and it's a travesty that more hospitals don't have it in place. I come from the perspective of a cardiothoracic surgeon where the Society of Thoracic Surgeons database has been in existence now for well over 20 years. There's over a million, well over a million patients who have been entered in the STS database. And I think it underscores the importance of data in terms of improving quality. Once you see the data, and I know it's been the experience in a number of states where there's public reporting of data, and we'll mention that momentarily, that usually the lowest quality place one year often is at the top of the list the next year. And the reason for that is because they recognize that there is room for improvement. And once they see the data, the will to improve certainly, and the incentive to improve certainly is there. There are several examples of this. The STS database started strictly with cardiac surgery. Within the past few years, it's extended to thoracic surgery, and that's not quite as robust at this point as the cardiac database, but it was incumbent upon cardiac surgeons to begin to look at their own data, to begin to look at the data in their own institution, and to be able to benchmark some quality initiatives so others could use them as well. I think a good example is the Northern New England Cardiovascular Disease Study Group that was actually founded back in 1987 with the purpose to develop and exchange information concerning the treatment of cardiovascular disease and to improve continuously the quality, safety, effectiveness, and cost of medical interventions. They actually every group in New England that did cardiac surgery participated in this. In 1991, they looked at the mortality among the centers. They reported a significant variation in mortality rates among the participating centers, and they, at that point, implemented a three-part intervention. And that involved continuous data feedback, quality improvement training for leaders and members of the consortium, multidisciplinary site visits. So a group of them went around to each of the hospitals looking what they were doing. And the goal of that was for one hospital to learn how another hospital's team conducted care. This resulted in a number of practice changes in the technical aspects of patient care, the organization of inpatient care, and the methods used for evaluating patients. And the result of this very quickly was a 24% regional reduction in adjusted mortality, with each center showing significant improvement. The other thing the STS has done, just to wrap this up, is a voluntary public reporting program. The STS has collected the data over the years, and then working with Consumer Reports now has a public reporting program that is voluntary. It's based on benchmark analyses from the National Cardiac Database. The primary rationale is transparency and accountability. The public reporting clearly facilitates quality improvement. There's no significant, interestingly, no significant impact on patient referral patterns or market share, despite the public reporting. And there is an emphasis to avoid the potential adverse consequences, such as the avoidance of any of the high-risk patients. You know, if you're so concerned about your outcomes, do you start avoiding the higher-risk patients? There are a couple of things. Appropriate implementation before you do public reporting is essential. The data has to be obtained from an audited clinical data registry, such as the STS data. And the STS is right now using some composite measures which are a variety of different elements that go into it. And interestingly, the reporting is focused on the program rather than on the individual surgeon level, which I think has caused more individual places and surgeons to participate. So the STS actually comes out with a composite score based on a number of factors, and it's just a 1-star, 2-star, 3-star rating for the institutions. I think it's been particularly effective thus far. I have to recognize my friend John Clark, who is very involved with the state in reporting patient safety, and Pennsylvania, of course, was one of the first states in the country to publicly report data and truly has served as a benchmark for others. So I think the bottom line is the importance of data in improving quality, and once individuals see the data, there tends to be significant improvement. And with that, I'll stop and pass it on. Thank you.
It is now my pleasure to introduce Dr. Glenn Steele, who is President and Chief Executive Officer of the Geisinger Health System, located in central and northeastern Pennsylvania. Dr. Steele joined Geisinger in March of 2001, where he has been very innovative in altering how health systems run, and Dr. Steele has gained national visibility as a result of these innovations and successes at Geisinger. Dr. Steele is also a member of the Institute of Medicine, as is Dr. Kaiser, and it shouldn't be lost on the audience that both Dr. Steele and Dr. Kaiser are surgeons. Dr. Steele, in his former life, was a surgical oncologist just a few years ago, and they have risen to be running very large health systems, and not just the surgical side, but the whole system. So, Dr. Steele.
Thanks. Thanks very much, Marshall. Just want to make a few points. First of all, I think there are two predicates to everything we've done up in the boonies at Geisinger, and probably everything we're going to try to do as a discipline in surgery. One predicate goes back to a fascinating article that was written by Beth McGlynn in her days at Rand and published in 2003 in the New England Journal, which basically surveyed a series of prevalent diagnoses and their treatments and had expert panels opine about whether those treatments were optimal. And what she found, to make a long story short, was that about 50% of those treatments were either too much, too little, or wrong. And when I read that, it was kind of an epiphany, because if we represent 1/6 of the economy in this country, and even if you discount that 50% for methodologic reasons, or you disagree with particular expert panels, just discount it to 30 to 40%. Just think about 30 to 40% of cost that is created that doesn't bring benefit to the people that we're supposed to serve. Just a remarkable upside. So our mission up at Geisinger, which is, as you all know, perfectly designed to do lots of experimental stuff because of our market share on both the payer and the provider side, because of a sweet spot between how you can look at claims data but then apply it to real live healthcare data with an electronic record. Our mission has been to try to do road tests to extract as much of that 30 to 40% of crap that actually may not be benefiting human beings or hurting them, and then redeploy that value. Redeploy the value. Now, some of the value has to go back to the people who are buying the care. Some of the value has to go back to the physicians who are providing the care, who get the credit. Some of the value has to go back to the insurance company as the broker, what have you. But that's where we're going to make the difference. I mean, fraud and abuse, everybody talks about fraud and abuse. It's big, we got to go after it. But the reason they talk about fraud and abuse is all of us can agree. I mean, it's bad. But what we have to talk about is redesigning care. And that's what John was getting to when he was asking a question about efficacy. And that's not easy. And the only way it can be done is by having, I believe, the expertise of the disciplines themselves actually do the registry work. Do the continuous feedback, and the second predicate is this overlap which I think is much greater than the figure over on Dr. Snyder's left. If what we've seen over the last 8 to 10 years is generalizable, almost all the time when you find a high-cost cohort, whether it's from hospital-based intervention or whether it's from caring for patients with ambulatory disease, almost all the time you find really, really suboptimal outcome. And if you believe that, and I believe that now, that those two circles really do overlap. So if you re-engineer care, you're doing two things, by and large, not all the time. You're actually potentially improving outcome, and you're attacking cost at the same time. So it's not either or. There's not this false polarity. And most of us go into medicine because we want to actually do good. And most of us will be motivated to do what has to be done to change care if we think it's going to help our patients. That's the professional pride of purpose that I think really drives us. You can talk about incentives, and that's all important, but most of us need more than incentives. If we're working against incentives, it's not good, but most of us need more than that. So let me just end by saying, why surgery? Well, surgery is particularly appropriate. And when we started redesigning our hospital-based care, we started with episodes of care where there was already off-the-shelf best practice defined in a dynamic way. So that was STS, and it was cardiology, basically. We sure as heck we weren't going to start with orthopedics. Oh, my goodness. But now they have registries as well, and they're moving along. The second thing is, with surgery, there's a starting point and an ending point, and we keep score. And it's important to keep score. Now, how we keep score is very important, and I think we're progressing in terms of having national metrics that are agreed upon, that are transparent, and can be used to feed back, and that's very important. And we're very competitive. We're very competitive. We like to see where we stand. So all those things are key. And we are immersed in unjustified variation. So for the acute re-engineering, one of the things that we've tried to do is to ask the question, if we attack unjustified variation and move to a default best practice, this is even outside of RCTs, will we affect quality and will we decrease, will we attack cost? Because in most complex areas of tasking, whether it's logistics or creating a product or what have you, if you have unjustified variation, two bad things happen. You get worse quality and you get increased cost. And I think what we've done is we've attacked a lot of the false accusations of we're creating robots and we're doing cookbook medicine and what have you, and there are various ways we can talk about that. So we're very excited about NSQIP. We're very excited about the STS database. The orthopedists are now doing this stuff really well. There are lots of benchmarking. And I think it's an ethical, compelling ethical case that all of us figure out outside of RCTs how we can learn from everything we do, feed it back, compare our results to others, and attack that efficacy issue. Thank you very much.
I have the privilege to introduce our last panelist. Dr. Mark Pauly is a professor at the Leonard Davis Institute of the Wharton School. The Leonard Davis Institute is a world-respected health policy institute associated with the Wharton School of Business. And Mark Pauly has gained a reputation as a serious and profound thinker about health policy. And he's also a skeptic. And that's useful in our discussions. So without further ado, I'll introduce Dr. Pauly.
Thank you. Thank you, Dr. Snyder. I felt a little guilty. I was quoted in a New York Times story earlier in the week on health IT saying something I agree with, which is, as with so many innovations in healthcare, the cheerleading often gets out ahead of the evidence. and the performance. But I actually feel much less guilty about that. I felt guilty in part because some of the leaders of that have been my former students and friends as well. But I feel much less guilty this morning because here I'm able to talk about something where the performance actually already is there, and now we're here for the cheerleading. And so I actually think that's wonderful, and it makes me feel much better, much less of a wet blanket. So that's, in my remarks, I'm going to make comments as a business school professor, a health services researcher, and a health policy person, and then I will conclude that more research is needed. So here's what I have to say from a business school perspective. And this relates to the skeptic role. Research and business and management actually is rather different than what you might think if you just read business books that you get off the book rack at the airport. And research on quality improvement methods, whether it's TQI, CQM, re-engineering or whatever, TQM rather, the general results from hard research is that often they don't work. You print up the T-shirt, you have the retreat, you sing the song, and it's all well and good. But if you actually look rigorously at whether it really made a difference or not, or whether you conclude for sure that it made a difference, you really can't find that kind of evidence. We're a little better off in healthcare based on the work of Steve Shortell out at Berkeley. Quality improvement in healthcare does seem to be more likely to have positive effect more often than not, or at least it beats the performance in other areas of business. But still, oftentimes it doesn't work, and at least I was not surprised but depressed by a CBO report last spring that looked at a couple of major Medicare initiatives to lower cost and improve quality. And although there were a few exceptions where they did work, across the board they didn't. So it's reasonable to be skeptical. But I want to say something positive, which is it's so nice to find something that really did work, and I think that's to be celebrated, and I believe further examined to try to find what was the secret ingredient that actually made it work this time. So that's my comment as a business school professor. As a health services researcher, you always want more, and you want more proof. And to some extent, although I started out life as an economist where we're willing to settle for a 0.1 significance level, I have been contaminated by my association with medicine to ask for more than that. And what I am impressed by the evidence on the performance of the quality improvements effort of the ACS. But as I said, you can always want to ask for more. And what I'd like to know is how does the performance of the participants in the effort that definitely showed an improvement from start to finish, how does that compare with what would have happened in a control group? I would be reasonably confident that you'd beat the control group, but you don't know until you try. My own judgment is that the things you worry about when things improve after you started them, the sort of thing Larry was talking about, is they didn't really improve. It was regression to the mean. I'm a little less worried about that here. I am worried, though, a bit about selection of patients and participants. In fact, a really interesting research study, if I could get a PhD student to do it, might be to look at what were the characteristics of the hospitals that volunteered to be part of this effort compared to those that didn't seize the opportunity, and see whether that tells you anything. One of the kinds of downsides you can worry about if you're a worrywart like I am was indicated by some research that was done on the healthcare report cards. Which I'm happy to say I think we're much better off with them than without them, so don't get me wrong. But what researchers, including some of my MD, PhD students, found was that when doctors were, and surgeons in particular, were given batting averages, there was a tendency to select those patients who'd make your batting average look good and to reject the patients that wouldn't. So you didn't want to treat the patients who were sicker than they looked, at least sicker than they looked to the risk measurement system, and that did lead to some problems in access, including for minority patients. So on the other hand, there's often really good positive Hawthorne effects from things like this, where once everybody gets the spirit of quality improvement, it can spread through the hospital beyond surgery to other parts. So I'm reasonably optimistic. And finally, not to be a total wet blanket, in management as opposed to medicine, you do not require randomized controlled trials for improvement in management to put them in place. You're willing to give them a shot and see what happens. To some extent, I'm not sure I would counsel that kind of view when it applies to new clinical treatments, but to some extent it may not be a bad idea for things that improve, potentially, or the promising ideas that will potentially improve quality and lower cost in healthcare, or as I put it when I'm pushed up against the wall, give it a shot and see if it works. Finally, from the point of view of policy, what is striking, which I think has already been mentioned a bit by Dr. Snyder, is that here we have a case where quality improvement came from the bottom up rather than the top down. As I already hinted in my comment on the CBO report, top-down efforts to improve quality and lower cost growth have not, in my reading of the research literature anyway, been all that successful. There are certainly exceptions. Geisinger's an exception, I'm happy to say, I'm proud to say, because I have some former students there too. But again, that's the exception rather than the rule. And there is a debate, I think, but I'm on the side of the school that believes that top-down re-engineering dictated, I won't sound like I'm running for office as a Republican here, but dictated from Washington may not work. And even the Institute of Medicine, I'm a member of the Institute of Medicine. I love the Institute of Medicine. I've spent a lot of days eating tricolor pasta salad on committee work at the Institute of Medicine, but it makes its decisions based on committees, and it's hard to get a hard-hitting report out of a committee. So what I guess the bouquet of the Valentine I want to give to the ACS here is you people did it from the bottom up, and God bless you. That's probably the right way to think about doing it. And the follow-on question, I guess, is there anything policymakers can do to help you continue that kind of strategy? One might be just get out of the way, but I think there's probably more than that. That there are things that could be done to help, including publicity and including flexibility, let us say, which frankly I'm happy to say CMS seems now to be showing a lot in allowing various strategies for improving quality and lowering costs. I'll close with something I'm a little worried about, also excited about, wonder what you think about. So if we look at situations where quality has been improved in other industries in the United States, other than healthcare, it has not, first of all, happened because of governmental intervention, of top-down intervention, or even, although occasionally there are industry committees that get together and make resolutions to improve quality, and they work, even from the top up in the industry. It's mostly from the bottom up, and the classic case study of quality improvement is Ford and the Taurus, not today's Taurus, but the ovoid model of the 1980s. And why did Ford improve the quality of the Taurus? Well, was it because the Ford family wanted to produce a high-quality car? I'm sure they did, but at least we don't think that was the reason. Was it because the engineers at Ford wanted to work on, didn't get up every morning and say, how can we make a junker? Let's make a good car. No, it was because Japanese cars were flooding the United States, and they were high quality. In order to compete with them, you had to improve quality. So I am a devotee of market orientation, and so I would like to see quality competition provide pressure and reward for healthcare providers that improve quality. I have worked in healthcare long enough to know that I shouldn't come across like Attila the economist and just say the markets will do it. There are certainly dangers, including the kind of report card manipulation that I just mentioned earlier. But I guess I want to have faith and hope that there may be ways to have an adult conversation with American consumers and patients about improving quality in healthcare, which would include telling them that you need to make wise choices I don't want to get anybody upset, but if there are to be centers of excellence, does that mean there are also to be centers of so-so? And where should I advise people to go? I think we do need to have a little more sharp-edged conversation about quality and hope that that will lead to improvement. Certainly consumers can't do this on their own. They need help, and figuring out ways to do that effectively is also, I think, likely to make a major contribution. Thank you.
So, Dr. Pauly, let me, we're not as far apart as you might think. In fact, I think we're pretty much on the same page. But to answer one of your questions about the distribution of the hospitals in the NSQIP data that I presented, this is a cross-section of suburban, urban hospitals, university hospitals, and different size hospitals. So we would agree also with your comment about verify, and that's what number 4 is on this cube, is don't just trust, but verify. And this is not a study that was done and we quit and we made some slides and trying to sell this. It's really an ongoing effort to try to improve the quality of care and reduce costs. So we really do agree with your assessment, and to provide data that is peer-reviewed. And also, for those who may not be familiar with the NSQIP process, the data collectors are not people, they're not surgeons. These are usually they're nurses who go through charts. They're not doing this with a bias. They're looking for objective information. And that's what we want. We don't want the anecdote of the surgeon that says, I've never had a complication. So we are trying to actually do this in a way that you would be proud of, Dr. Pauly. So we are a little bit behind our schedule, but we do definitely want to have questions from the audience. So please, this is your opportunity to ask questions.
Hi, my name is Gina Siddiqui, and I'm a medical student at the University of Penn. And I just wanted to ask about the release of data in NSQIP. Dr. Kukar, you mentioned in your consortium discussing and kind of sharing outcomes. And then Dr. Kaiser, you mentioned an optional release of information to the public from the cardiothoracic database. And I just wanted to ask if it's required in NSQIP or if it's an option, and especially with the government agencies now that are starting to collect outcomes data, and what impact you think that has on the competitive efficacy of this data we're collecting.
Go ahead, John.
I feel I can handle that question fairly well. One of the latest options within NSQIP is to allow sharing of 3 measures. You can pick 1, 2, or 3 of them from your hospital's database, and it's going to be linked automatically to the Center for Medicare and Medicaid Services Hospital Compare website. So in addition to the abstracted Medicare outcomes data and fiscal data and volume data for allowing patients to basically select the hospital that they might want to use that information for, if you elect this now, you can have your hospital's data put on the CMS. That started this month. I just got a letter from the College of Surgeons thanking us for being one of the initial participants in that, and at the moment it looked to me like there's about 100 of the 400 hospitals that are going to public reporting, at least at this point in time. Hopefully that will become almost the norm, but I think some hospital administrators want discretionary ability to perhaps not put their data out there if it doesn't look so good. Glenn.
Yeah, let me just follow up to that. It's amazed me when I talk to boards of trustees who are responsible, obviously, fiduciaries, how little they understand about real quality monitoring. And one of the test questions that I ask them when I'm interacting with them is, what is your observed over expected mortality? Now, you can quibble about stratification, methodology, what have you, but it's gotten a lot better over the last decade. And so I think one of the issues is not just transparency to the outside world. One of the issues is understanding and transparency to the fiduciaries who are responsible for that hospital. So I just wanted to mention this. Very, very important.
I think the other thing about the public reporting, the state of Pennsylvania has been doing it a long time. Unfortunately, the half-life of that information is vanishingly short. I'm not sure the public actually uses it to any great extent to direct their medical care, which is unfortunate. I think there's a much greater use of the U.S. News and World Report, which is not exactly based on the most rigorous data collection. So it's unfortunate, and hopefully there will be some change and some shift as we go about more public reporting of these data.
There's evidence, in fact, that the public does not use it. There's evidence, and Mark, you know
yeah,
that.
so that's the worrisome part I was talking about. The positive impacts of releasing data seem to come not because it leads to rearrangement of the market share away from the bad performing places to the good performing places, but from peer pressure amongst physicians and hospitals. These, as probably the questioner knows too, you were selected because you were a highly competitive person, and you don't want to look worse than your peers. And most people don't get up every morning and think I'm going to do a terrible job today, but until they get data comparing them, they don't know where there's room for improvement. And so that seems to be the biggest impact. I'm not a total wet blanket on this, though. I think there may be ways, as I suggested, of making the public, not only making the data available to the public, but also helping them interpret it, that could double up on the incentives and the rewards for quality improvement. But right now, in some ways, the economist nirvana of as if by an invisible hand, people would go to high quality hospitals and surgeons is in the future, not in the present.
There is an experiment, an old experiment, which is essentially being redone, just starting to be redone right now. Walmart announced yesterday that they would be sending their elective heart surgery and elective catheterization to 3 centers of excellence in the United States. And they would be sending their spine problems to 3 centers of excellence in the United States. Now, that's an old experiment. They're giving their employees $1,000 of funny money if they should choose to go to those centers. They're not mandating it, but they're trying to incent it. So, I mean, it will be interesting to see if that experiment starts to generalize again. And some of the basis is on outcomes, obviously, and cost.
It shows how strange it is. We'll give you $1,000 to move from McDonald's to Lebec Fan.
One of the problems, though, with public reporting is oftentimes it's not risk adjusted. And an anecdote: when I was in UC Davis in Sacramento, the state of California in the early '90s published results from hospitals on cardiac surgery, particularly coronary artery bypass. It was not risk adjusted, and the hospitals that had the best results, no one had ever heard of. Whereas the university hospitals, who tend to get the most complicated patients with comorbidities, didn't have such good results. And so public reporting is good, but it needs to be risk adjusted.
And even if it is risk adjusted, there's argument about how you adjust the risk. And those that have done well think it's great, and those that haven't will argue that the risk adjustment was done poorly. So it's a complex situation, to be sure.
Other questions?
Good morning. I'm Stu Fine. I'm the CEO of Grandview Hospital in Bucks County. I have the pleasure of sitting between Larry and Glenn at the Hospital Association board meetings. Why are we not bringing something like this before the Hospital Association board to see if Pennsylvania's hospitals as a group would endorse the initiative? Why is PMS, which is chaired by one of my employed surgeons with whom I'm going to have to speak when I get back to the shop today, not bringing this forward to every medical executive committee at hospitals in the Commonwealth? Why is Casad Insurance Company, of which Abington is a major part, of which I'm the past chair, not hearing from its physician executives that this is an initiative that must be endorsed by the 1,300 non-employed surgeons who receive their or secure their professional liability insurance through that entity, or the 6 health systems.
Yeah, it is somewhat of an incestuous group today. I mean, we're sort of talking amongst ourselves here about this, but you know, it's a good point, and it certainly has not been something we've discussed at the HAP board meetings, and it would be, I think, beneficial if, you know, if HAP did endorse it. I think it gets into what Dr. Pauly was talking about with some of the top-down, and we're already seeing a fair bit of top-down with no payment for readmissions and surgical site infections and a few other things. But I think you're absolutely right. I think some of the audience that needs to hear this have not yet heard this, and certainly that is something I think that is important. The American College of Surgeons basically is doing this in some cities around the country to other surgeons, basically. So hopefully some of them will come and take it back to their own hospitals that are not participating currently in the NSQIP program.
One of the issues that the local consortium of 10 hospitals is trying to move toward is to having a collaboration between regional insurers and an enablement thereby to have more hospitals regionally join NSQIP and be part of the consortium. Many consortiums are, in fact, having most of their administrative costs covered by regional insurers. As an example, the Tennessee Consortium, originally the Michigan Consortium, which is no longer part of NSQIP but is still functional, had its underpinnings from regional insurers trying to get better value for the healthcare dollar spent. And I think there's an opportunity here in Pennsylvania for the consortium to collaborate potentially with regional insurers.
It may be worthwhile commenting that Generation 2 NSQIP is coming. It's been found after 20 years of experience that a third of the data points will stratify just as well as the 135 that a classical NSQIP it was involved in collecting. Generation 2 will cost a lot less, easier to implement. And I think there's a political dimension of this because I think the college should be taking to Capitol Hill the concept that Generation 2 NSQIP is inexpensive and it's low-hanging fruit for CMS to reduce costs.
So just to add a little bit more, which is an excellent question that you raised, but there have been examples of what you're talking about in Michigan, in Tennessee, and in Florida. Different mechanisms. In Michigan, it was Blue Cross that put this in all of their hospitals in the state. Consortium in Florida and in Tennessee did this as well. Why this hasn't been brought to the Pennsylvania Hospital Association, I can't answer that. There is a significant effort in discussions with CMS because that's really where the best bang for the buck is. If you can get the Center of Medicaid and Medicare services to adopt a form of this process in all the hospitals, that's where the real savings come from. But more importantly, they're going to be focused on savings. We're focused on less deaths and less complications. Other questions?
Yes, all of us here who have tried hard to work on the quality improvement, cost reduction, access, have been sobered by the data that Dr. Steele mentioned about the high level of inappropriate or inefficient care in this country. So Dr. Steele has received national recognition for the way he's integrated not just his institution, but the physicians inside of that. And so I would like to get a couple words from Dr. Steele, some advice for people like us. I've spent a good part of my career trying to get physicians to align their performance with an organization, mostly private practicing. So other than hiring them, which I know is essentially what you've done, you said that it's not all about financial incentive, though, so we'd like to hear what advice you have for us about how do you align the physicians with these initiatives?
Well, first of all, we're very heterogeneous, so we're not like Kaiser. It's not a closed system. And a huge amount of our insurance company care for its members is given by 25,000 non-employed, non-Geisinger practitioners. And we're really proud of the fact that the insurance company, whether you're looking at the Medicare HMO or the Medicare PPO or commercial, are all ranked #1 in Pennsylvania. And they're ranked in the top 6 to 8 in the country. And it's the only non-closed staff insurance company that is up that high. I mean, if you're closed staff and you control the total cash compensation and the levers and all the levers, you know, it's still hard to do, but it's a lot easier than in the real world. And what we've tried to do is figure out, obviously you can't go directly to total cash compensation and change the incentives and what have you, because these folks are in private practice. But what you can do now, because Stark antitrust has been mitigated to a large extent, is put data feedback in a much more intensive way. You can actually even put hardware in now without being accused of antitrust. You can we pay up to 1/3 of our non-Geisinger physicians who are in the panel for quality and efficacy outcomes, up to 1/3. So it's not like 3% or 5%. And we basically do an awful lot of sociology where we look at different non-Geisinger groups and say, how are they doing better? Now, we can't do that in the same market area because, you know, it's competitive and what have you. So it's doable. It's hard, but it is doable. I mean, the last thing we want to do is to employ more physicians, trust me, particularly orthopedists. Jeez, I'm just kidding about the orthopedists. They're special.
Maybe 1 or 2 more questions? Yes.
Hi, my name is Joe Montella. I'm a GYN surgeon at Jefferson. Thank you all for your input on this. It's been a great learning experience, and I commend you all for putting this program into place because it is important. My question is what can you recommend to convince insurers, hospitals, that there is a business case for putting these quality programs in? The outlay of expense is at time 0, but we may not see the benefit for 10, 20 years later. So what are your best practices in terms of how to convince people to do this?
First of all, there's no single answer to that. In our situation, it's backfill. If we're doing the right thing and keeping unnecessary complications, if we're keeping complications, there's no such thing as if we're keeping complications down to a minimum, if we're keeping unnecessary rehospitalizations down to a minimum, we have an incredible disease burden up in our area, and we keep bringing other patients in. Basically, that's #1. So instead of building a bigger house, we get in an area that's very competitive, like Philadelphia or in the main line. If you're to do this and you're creating value, one of the business model responses is increase market share, particularly if your brand is almost the best brand. If it's right close, you should increase market share. The third thing is, you know, most of us are predicting a different type of payment model, whether it's shared savings or whether it's going back to quasi-capitation or capitation. And even though right now we're still predominantly getting paid fee for service, I think most of us are worried that at some point we're going to be rewarded for an attack on total cost of care as long as we're not hurting patients. So it's a very complex discussion that is really market specific. And I can tell you one thing, if you don't have a business model for this, that trumps all the goodwill and good intention in the world. I mean, from a macro perspective.
Good morning. Thank you, panelists. Excellent job. I'm Chuch Malik. I'm a CT surgeon, pediatric CT surgeon, disciple of Marshall Schwartz. And I was listening to this conversation very carefully, and there are certain things that we need to look at, the pitfalls of data reporting. when Marshall was talking about risk adjustment and risk stratification, certain hospitals do not have the same patient population. So databases are not that extensive and accurate at the moment. So as a pediatric cardiac surgeon, PHC4 is the Pennsylvania Health Containment Council, has come forward and asked for all our data as pediatric heart centers come forward and report it publicly. That's a great initiative. But if you look back at data of African American and poor socioeconomic patients with Norwood operation, it's a single left ventricle operation, then there were no survivors till 2003 in Boston. And that is all the patients we get. So in the data that comes out, and we are in a market where it's a business of medicine. If you see a data where you have African American, all the patients with Norwood with a 50% mortality compared to a hospital predominantly, which is Caucasian, hypoplastic left heart, with an 80% survival. And this could be taken forward in a forum which is not appropriate for marketing reasons. And we have had discussions over and over again. And the population is very skewed in certain hospitals. I'm not saying it's a bad thing. We should all report our data. We are willing, everybody wants to share the data. But all these things are not put in asterisks. So it's important that whenever data is reported, these things are put in asterisks because nothing is perfect. Number two, coming back to the Walmart issue, I think it's something to look forward. The Government Accountability Office in 2011 came forward with the data and actually everyone looking towards transparency of healthcare costs, which no one addressed today. And in Denver, they saw 5 hospitals doing orthopedic surgery with knee replacements between $35,000 to $110,000. So that is something they would look at. And organizations like Walmart would go forward looking at that as a primary more than quality. As much as quality, look at costs. And going back to something that I was involved in 2001, and this will surprise many of you, that I was leading a healthcare group worldwide called Fortis Healthcare. And we actually came and met GE to outsource healthcare to our country. I was in India at that time in Delhi. And if they could come and send patients there for X amount of dollars. And that is where I think the future is heading towards. Thank you.
Thank you. I think we need to bring this to a close because we promised we'd be done on time, and we're a little bit over. I certainly want to thank all of you for coming out this morning. I do want to leave you with a message, and actually it was a message that Congressman Gerlach said in his presentation, and that is, if we're going to have an impact on how healthcare changes, we as physicians and surgeons need to get involved in this process. If we're not involved, then we're going to have to accept what's delivered to us. So whether it's you as an individual, you as a member of an organization, encourage your other members, get involved yourself locally in the state as well as in Washington. This is what the American College of Surgeons made the decision to do about a decade ago. The college had not really been very involved in Washington, and as a result, we were not really at the table when these questions were arose in Washington in terms of what to do. That's changing, and I think we can change it more if we all come forward and say this is what we think should be done. Howard, last comments?
I think this is an important initiative because I feel that as we as physicians don't take the lead, this quality improvement, cost reduction effort won't happen. Thank you.
Thank you all.
Good to see you again. You're